Well, of course, this is indeed a shift of geography, but now we are going to Western Europe, and I'm telling you a little bit about the Netherlands, where we implemented HPV-based screening already. Just in short, I think a lot of people know this already, but I think it's good to summarize what are the changes in the Dutch screening program. We had a cytology-based, also already a nationwide population-based screening program that was cytology-based until 2016, where we had clinical samples taken by GPs and had a cytology test where all high sales were referred to a gynecologist and all ASCAs and low sales had a follow-up smear in 6 months. So that was our old program. And then we switched with like a big bang, the whole country, which is of course a small country, but still, in 2017. And since then we have an HPV-based screening where women are screened in the same age, 30 till 60, but we added an extra round at 65 when a woman is HPV positive at 60. And also we deleted some rounds. So now we have only five screening rounds in a lifetime, which is, I think, the lowest in the world for organized screening programs. Of course, that is. I think a lot of countries would be happy with five screens for a woman in her lifetime. Which means we have a 5 years interval, but we also have a 10 years interval for women who are HPV negative and 40 or 50 years old. Another thing that we changed, this session is not really about this, but I want to mention is that we added self-sampling for our non-responders. So for women who do not want to participate to the normal screening with the pap smear, we have now the option that they can order a self-sample device, which is off-label. We talked about this morning, but I will come back to that later. And our test and triage at this moment is that we first do an HPV test, and only if a sample is HPV positive, then we do a cytology screen. When you are HPV positive and there are no abnormal cells at all, you will have a pap smear in 6 months with your GP. And if you do have a HPV positive and an ASCA, so ASCA's low seal, high seal, everyone is referred to a gynecologist. So our triage is a little bit different than that we had before. Let me switch back. For the more visual people of you, I have this little image which shows that a woman, after an invitation, which we will receive automatically, she will make an appointment at the GP office. The sample is only tested for HPV. If it's negative, then that is the end of the screening round. But if it's positive, then we will have a follow-up cytology. If it's negative, you will be referred back to your GP. And if it's positive from ASCAs on, you will be referred to a gynecologist. So HPV positive women with no abnormal cells will have a follow-up smear in 6 months. And I have to, little side note, that women are sometimes quite worried that they are HPV positive and not referred to a gynecologist. So we have to explain that only being HPV positive without any abnormal cells is not a problem at that point. So they have a follow-up smear in 6 months, so the GP can check with a sample at the laboratory if there are any abnormal cells. If there still are no abnormal cells, she can wait 5 years for her next screening round. So there's no triage HPV test. This is only cytology. And then we have the self-sampling device, which is of course a little bit different. When a woman orders a self-sampling device and she returns it to the lab, it's tested for HPV, but of course there is no cytology possible at the moment at the self-samples. So if she's HPV positive, she will be invited to make an appointment with her GP for a pap smear, which then will be cytologically assessed. So we have a little bit lost to follow up, of course. Women who are HPV positive with a self-sample and do not go to their GP, but it's necessary at this time. Although this session is not about the results of HPV screening, I think it's nice to have a little bit of these results. So this is my only results slide. I think there's a lot to tell, but we've already shared, of course, in other places. But I think for now, just to point out a few things you can see, I think the most important is the detection. which you can see right in the middle, and you can see that I cannot point. Can I? I can. That our detection has increased quite significant. So you can see that we have a higher detection now with our HPV screening, which we started in 2017, but at the cost of quite significant referral rates increased too. Our referral almost doubled. And also this means our positive predictive value has decreased. So those are some things that we are paying attention to when we want to make further improvements in our program. But like I said, this session is not about the results, it's about implementation. So I want to tell you a little bit about the implementation of this HPV screening program in the Netherlands. And like I said, we already had, of course, a nationwide population-based screening program. So this means we have a really good registry of addresses and date of birth and things like that in the Netherlands. I think that's a big pro that we have in the Western world. And we have a system in the Netherlands where our Ministry of Health, of course, will have a health council, a national health council to advise, but then they will make the decision to switch to HPV screening in this case. And then because I'm working at the Center for Population-Based Screening, we'll implement this new program in the Netherlands by all parts, of course, all kinds of organizations that you need in this chain-like work, which is needed for population-based screening. We have a lot of screening organization, people working there who send out the letters and answer the telephones and do a lot of quality assurance and communication work. And then, of course, there is a whole range of professionals like the GPs who are quite diverse in the Netherlands and the laboratories. And all these organizations and people were, of course, also involved in the implementation, because I think, like what Mario also said, there are a lot of people who have questions when you want to have a big change like this, which also has a real big influence on a lot of people's jobs. I think it will take time to make a switch like this. So in the Netherlands, it was something like this. The decision-making took 2 years. Like I said, the National Health Council had to make an advice on this, and the ministry had to make their decisions. And for that, you have to find a lot of literature, of course, to make this kind of decisions. But when the decision was made, we had the preparation phase, and it also took years. In the Netherlands, we are obliged to have tenders. So we had a tender for the HPV test, we have a tender for the self-sampling device, for the laboratories, and for all smaller things around that, like postage and packaging. We did these tenders. Then we had, of course, the organization, the IT frameworks, all guidelines, the communication materials. You have to develop a lot of things before you can do this. And then we had 8 months for the implementation. So where we did setup and testing, and we did a workflow with a low volume. And then we made the transition. And like I said, it was like a big bang. So on January 1st in 2017, we stopped the cytology program and started the HPV program. To stop the cytology screening program, we had the concentration of the invitations before that. So we wanted all the invitations before September, and then we informed the clients and the GPs that the cytology screening would stop, and that they had to take the smears before December to give the opportunity to the labs to finish the cytology. And we also switched the IT system, which is a whole project on itself. The communication, I think, is quite complex when you want to switch to HPV screening, because it has a lot to do with STDs and all. Well, it's a little bit of taboo, I think, also even in the Netherlands. And we are quite clear in our communication. I think it took a lot of time to make this with pre-test in the women, but one of the complicating factors, I think, was that we have a little bit of a different message from the HPV vaccination, where it said, hey, HPV, it's deadly, it can cause cancer. You need to have your vaccination, which is true, and which we support. But in the screening, you don't want to worry people that if they have an HPV infection, because a lot of women are HPV positive, and we don't want them to worry and to think they're going to die just because they have an HPV infection. So this kind of mixed message that like HPV is very, very, very worrisome, or it's not, I think was something that you need to balance when you have HPV screening and HPV vaccination. A little bit about the quality assurance in HPV screening, because we were one of the first countries we had to set up the quality assurance, and it took a lot of our attention. We have only 5 test sites in the Netherlands. So in the old program, we had like 40 laboratories. Now we have only 5, which means they all use the same test equipment, and they all are in the same quality assurance program. With, of course, we need to make fast adjustments if it's required, because in the first years we will have all this, little things that pop up, and we have to pay attention to. And also, of course, your quality assurance for your cytology will change. Because we have a very more increased abnormal cytology, and we were a little bit worried about HPV bias. So we also had to change the quality assurance in the cytology triage. I have a little bit, I know this is not really about the process of optimization further on, but I want to point out a few things. We are investigating the possibilities to decrease that number of unnecessary referrals. Like I pointed out, we have our positive predictive value has decreased, and we are looking into possibilities to further adjust our triage. And one of the things we are considering is adding genotyping to our triage. Then the second thing we want to make better in the program is the position of self-sampling, because right now we are only offering self-samples to non-responders, but they have to order it. And we know from literature, but also from our own experience, that is not the most effective way to use self-sampling. So we'd like to start sending them out actively to non-responders, and also to all the first invited women. So in our case, the 30 years old, because that's the group of women with the highest risk, but also the lowest participation, and they are the most inclined to use self-sampling. So that's our plan. But like we talked about this morning, and also in the Netherlands, it's quite a discussion of using off-label, and we want validated self-sample devices, of course. Then we are preparing in the Netherlands for HPV vaccinated women. Since we only screen from 30 years old, our first vaccinated women still have to enter our program, which will happen in 2023. And also we are trying to lower our barriers for participation, because we do not reach that 70% at the moment. And we want to make it easier for women to participate. And for the last bullet, I think we will deal with that tomorrow in the program, but we are, of course, dealing with consequences of the COVID-19 pandemic, which is a whole other story, and I would like to discuss that with you further on, so I'm looking forward to that. Well, thanks to all the partners, of course, in the Netherlands in this program, and any further information is, of course, in our website. Feel free to email me, and I think I saw a lot of chats popping up, so I think there will be questions at the end of this session. Thank you for now.